Hello everyone, welcome to the second episode of MedUpdate. My name is Zehran, a student with aspirations to become a doctor. In this podcast, we discover the new developments of medical treatment in detail. I hope you are all having a fantastic day so far. This time, I will be joined by two of my great friends, Taha Khaji and Fahad Sultan, who intend to become doctors as well. This episode, we will be discussing several updates in cardiology with our distinguished guest, Dr. Amanulla Khaji. Our guest is a consultant cardiologist who has implemented the developments that we will talk about today. Thank you so much for joining us today, Dr. Khaji. First of all, could you tell us more about your background and successes?
Thank you so much. First of all, I would like to send my gratitude for inviting me to be part of this podcast, which is arranged by all you young people, and it gives me an immense pleasure. It's a different kind of meeting that I've been part of. So thank you so much. And as
You're
far
very
as me,
welcome.
I am Dr. Amanulla Khaji. I'm a cardiac electrophysiologist, which essentially means a cardiologist specializes in managing and treatment of heart rhythm disorders. Currently, I'm practicing in Chester County Hospital, which is in the suburbs of Philadelphia, United States of America, for the last almost 15 years now.
Yeah.
So I did my training and everything, initially school days and college in India. Then I did spend some time in the United Kingdom, and then eventually came to America. So here I am now, practicing and enjoying my work, I would say.
Thank you. And let's first ask you about the first section that we will be covering, and that is the monitoring of heart problems. And Daha will be asking you about this.
Perfect. Dr. Amanulla Khaji, can we begin by outlining some of the most common heart problems present in the world at the moment?
Absolutely. Thank you so much for that question, Taha. And I always tell when I'm describing heart problems into simple 4 or 5 categories. Now, what I mean by that is, imagine heart as like a house. The house has, electricity, house has plumbing, house has windows, doors, and a structure, right? So cardiac problems can be divided into 5 categories. The most common and the most dangerous one that we always hear is heart attack. That is essentially blocked arteries of the heart that supply blood, and that's plumbing situation. Number two, then there is electrical abnormalities. The heart has an amazing electrical cables, believe it or not, that are not seen to the eyes when you open the heart structure, but they're all laid out all over the heart muscle in a very intricate, delicate fashion. And any abnormalities in the electrical connections in the heart will lead to dangerous, life-threatening problems. And that is called cardiac electrophysiology. I am a specialist who manages patients with electrical problems in the heart. And that's why sometimes I introduced myself. I'm the electrician of the heart. So that's number two. Number three is doors and windows in the heart, right? So there are valves which control the flow of the blood back and forth. When they wear out, when they leak, when they don't work, close or open properly, those are valve problems, and that can be presenting with symptoms such as difficulty breathing or swelling in the body and chest pain and things like that. And the fourth problem is the overall structure of the house, right? Like if you think of it, the heart is a muscular pump. Now, the pump can fail, and the most common name for that is called congestive heart failure. So, those are the 4 primary categories of heart diseases. That is, problems in the blocked arteries, problems in the electrical wires, issues with the valves, and then the congestive heart failure. There is another area in the cardiology that is developing, which is very much right now a hot topic, is prevention. Means everybody wants to prevent disease, not wait until disease happens. So that is preventive cardiology.
Ah, So you could probably say the most common heart problem present at the moment is the blockage of arteries in the heart, right?
Exactly right. Yes. In fact, until COVID came to the world, the cardiac diseases or heart disease, especially heart attacks, are still the number one cause of death in the world. So it's a very common problem. And the good thing about that is it is also a preventable cause of death. If you do some, appropriate care, treatment, life can be saved.
Yeah. So what are the biomarkers that are used to diagnose these problems, and what are biomarkers in the first place?
Excellent question. I like that. So, we always are looking forward to diagnose these problems as early as possible. Because remember one thing, if somebody's having heart attack, the worst thing that can happen is we wait to diagnose that problem. Because if we wait longer, treatment can be delayed. The delayed treatment means life and death. So we are always looking for clues or signs that we can detect way ahead of a heart attack problem. So biomarkers are essentially these chemicals, or you can say naturally occurring proteins that are released by damaged or stressed out heart in the setting of heart attack way before major heart attack happens. So biomarkers, by the name itself, biology markers, they actually tell us something. And the most commonly used biomarker I use on a day-to-day basis is called troponin. Troponin is an enzyme that is leaked by a heart muscle that has suffered a heart attack. And it is so sensitive that if you're having a chest pain, that I check routine testing and I do not feel that this is a heart attack, a biomarker can tell me that this is actually imminent heart attack. That way we can take care of the patients well ahead of time and manage and take care of them. In fact, we did that a patient just yesterday where somebody who comes with chest pain, ECG, which is an electrocardiogram, electrical recording of the heart muscle, did not show heart attack. But when we added the biomarker, was significantly elevated, which tells us this patient needs to go to the emergently to the heart catheterization lab. And surprise, there was no surprise to find that this patient had multiple blockages that needed an emergency bypass surgery. Imagine if we had waited this patient for 2 days, 3 days. Today is a holiday in America, means life and death. So biomarkers are really helpful for us in a day-to-day basis. There are many other biomarkers available, but I just want to give an example of troponin.
Yeah. So it's clear that biomarkers do assist cardiology vastly.
Absolutely.
Um,
Most independent specialty.
Sorry?
It's probably the most dependent specialty for biomarkers of all the specialties in medicine surgery. We rely on biomarkers a lot. Go ahead, sorry.
So what instruments and methods would you use typically to monitor heart problems?
So monitoring of heart problems, right? So we are now in 2023, we have a lot of cool gadgets, okay? And now traditionally what we use is a big machine called ECG, electrocardiogram, which records the electrical activity of the heart. It looks like a big suitcase with a lot of wires, very cumbersome, but gives us a good information. But in 2023, we have a lot of options for patients monitoring their heart rhythm problems, which can be as small as a little patch or a sticker that sticks on the chest wall and records electrical activity, sends information 24/7. We have even Apple Watches, which we are going to discuss as well. The Apple Watches, at least 6, 7 years ago, came across this additional feature of monitoring your ECG in the wrist, and gives a pretty. And I have a lot of patients who actually inquire about this, use it, and they do send me their electrical recording. So then there is also patients of mine who have actually pacemakers and defibrillators. These are devices that manage and treat heart rhythm problems, but for them to be checked and tested, we use monitors. They send information that patient can that data can be downloaded in the internet and send it to me. The patient can be having a vacation in Florida or some corner of Japan, but by sending the information wirelessly via internet, I can literally get all the information that I need to know about the pacemaker or defibrillator via internet about that patient, So it's pretty cool. We have a lot of options. It's a lot of things to talk about, but we have evolved quite a bit, and these technologies are developing super fast.
Perfect. So what have been the advancements? Sorry. What have been the advancements in the monitoring of heart problems recently? As you mentioned, the
I think,
ECG and defibrillators
yeah,
are used to monitor them, but have there been any newer ones recently that have come up?
yeah. I would say there has been a revolution in heart monitoring stuff. If I had to give you two extreme examples, 20, 30 years ago, patient had to call on the phone, sit there for half an hour, call the doctor's office, relay the information remotely, or the best way was go to the doctor's office and then get all the information. Now, as I said to you, they have become more fast. They can be information can be downloaded from internet by connecting these devices, irrespective of where the patient is. And these devices have become so user-friendly and smaller because then they can put in the pocket of your pants instead of these big suitcases laden devices that used to be there for 20, 30 years ago. So we have now iPads that we use to diagnose or device check, which used to be like big suitcases, like a regular travel luggage suitcases. Now I check my pacemaker patients on an iPad, which is incredible achievement, and I think more to come. This is an exciting field of my field, electrophysiology, where we are doing a lot of technological innovations in making patients care better, easier for doctors, and it is cool.
So you've mentioned that these machines that monitor heart problems, they have many advantages such as convenience and size and comfortability, but are there any disadvantages as well?
That's a great question. I really like that question. You are smart. I think the important thing to remember is this. I don't know. I mean, working and talking to young people, I always feel I'm out of place where I cannot be in sync with the new terms. I don't know whether you know this term called TMI, means too much information, right?
Yeah.
So what is the disadvantage of these monitors is now you are getting so much data from the patients that you have to process and you don't know what to do about it sometimes. So having all this information is important, but at the same time, if you're bombarded with so much information, it causes a lot of anxiety on the patient if they're worried about something. I have patients whose Apple Watch says atrial fibrillation. The next thing to do is, oh my God, this is so serious. Let me call my doctor. And then when I had to download the information, check on it and says, oh, this does not look that bad. You're okay. So what has happened is it has caused a lot of traffic in terms of communication. You see my point? So there are some disadvantages. So, you need data, but at the same time, too much data is too much to process. Hence, a new field that is emerging, and which we'll talk about it, is artificial intelligence, which is going to help us to process that data, package it in a nice small packets, and give it to us as doctors, whatever we need, so make our life easier. So that's a big disadvantage of the monitoring devices.
So the advantage of there being lots of information can also act as quite negative because it's hard to essentially observe what they need to look at, right?
Yeah. Like if I had to give an analogy, just to take 30 seconds, like if you're managing bunch of kids, right? And you tell the kids, I want you to come and tell me if there is any problem that you're facing. And if you're talking to 2 kids versus you're talking to 35 kids, now what's going to happen?
Yeah.
Okay. 35 kids are going to tell you 60 complaints. You will be like losing your mind, right? Like, what are you going to do with this? I told them to come and tell me, but if there are 2 people, it's easier to manage. So that's the analogy I would give best to understand that.
It's a lot more hectic and stuff.
Yep.
So now let's focus on a more intricate side of monitoring of heart problems, wearable devices. This is section 2 of the podcast. How do
Mhm.
you how do you believe wearable devices such as the Apple Watch monitor heart rate and rhythm?
Mhm. Can you repeat that question? I think I lost a little bit of words when you put that question. I just heard wearable devices.
Yeah,
Sorry about that.
that's fine. So, how do wearable devices such as the Apple and Samsung Watch monitor heart rate and rhythm?
Okay. Yeah. I think that is the most talked about topic. Apple Watches came around, they have been there for a decade, but for the last 6, 7 years, they added this feature of monitoring your heart rhythm, which is essentially a single lead ECG or electrocardiogram of the heart, which typically is a 12 lead, 12 channels of information that we traditionally do in our office. So one lead is sometimes good enough to give us a lot of information. There was a study that was done in Stanford University, California, where they had 400,000 people using this Apple Watches and testing the accuracy of these devices, Apple Watches, compared to our traditional ECG machines and correlate how good they are. And to reveal the results of the study, it was amazing. 85 to 90% of the time, the Apple Watch were pretty much accurate compared to a regular monitoring device that we use as doctors. And that actually caused an explosion of using Apple Watches as a preferred method of monitoring for some patients, not everyone, because the decision to use Apple Watch right now can be individual, but what information to send, where to send, there is a lot of inconsistency. So it's a great tool to have, but a lot of it is in development.
So needed, yeah. So, has this new technology improved upon the current methods of diagnosis for heart problems?
Excellent. You
Yeah.
know, I think that's the best example of that I would give you is this. A patient of mine who was, having these episodes of heart racing. And every time he would come to our office, his episodes will disappear. And we do the EKG, everything looks normal, right? So he had to wear a monitor. But his symptoms were unpredictable, happening once every week, sometimes once every 3 weeks. So there was this unpredictable time frequency that we needed ECG at the time exactly when he feels it. So I suggested to get an Apple Watch, and which he did. He was able to afford. I don't usually try to market for Apple products, but I just tell it more for the sake of monitoring. So he does buy it, and he has an episode. He records it. Once he records it, he sends me to the office in email format. Comes as a PDF. I look at it, and it shows me an abnormal, dangerous heart rhythm. As soon as I see it, I say, I know what you're having, what problem you're having. I will take care of it. It needs a procedure called ablation. The diagnosis is called supraventricular tachycardia or SVT. Can be serious heart rhythm problem that can make you pass out, lightheaded. So you can see just having wearing our Apple Watch literally diagnosed a problem that our traditional machine that we are using could not give us information because we needed ECG at the time when he had episodes. So it really helps. So it does help in diagnosis of heart rhythm problem. Hope that answers question.
Yeah, quite well. Would you argue that after you use the Apple Watch to record the ECG and stuff, would you argue that
Absolutely. Absolutely. I
further?
would say ECG can be never be replaced because that's the standard, gold standard. As I said, Apple Watch is 85% accurate, not 100%. And a lot of times I'm spending time in reassuring the patient when they come up with, I gave the best example, but there are examples on a day-to-day basis where Apple Watch will call whatever abnormal. Patients panic, they call me, I look at it, hey, this looks fine, nothing to worry about. If I'm concerned, I'm not sure, I ask them to get a 12 lead ECG, and that's the way to check things out. So it has to be always checked by a doctor to make sure we're dealing with this. That's the most important part.
Yeah, okay. So, are there any limitations or issues using Apple devices, well, the Apple Watch or other wearable devices, as part of the diagnosis?
Yeah, I think, as I said, the biggest challenge is the um, the information volume is a problem, and we don't have a good, and the accuracy of these devices, as I said, it's not 100%, so it's not the best. I think they're going to get better and better. In fact, one of the new devices called Cardia or Alive Core came up with 6-lead ECG, which is compared to 1-lead ECG of the Apple Watch. So people are innovating things. It has not completely replaced the traditional stuff, and the information you get can sometimes be, you know, not reliable, and that's important. And also, there is a lacking system of communication between the devices, letting patients know, and also having patients call the doctor's office, taking appropriate timely care. Those things are still weak links. So those needs to be, eventually addressed in a very systematic fashion, because all these things put together will make a successful case diagnosis and treatment.
So would you suggest your patients to use wearable devices to diagnose heart problems in their daily lives, or just come to?
Absolutely, I would advise, and I do that on a day-to-day basis, but only in patients that I think it's appropriate. When I say I think, I'm not trying to be a, like a dictator to tell people what to do, but as a physician, when it is important to, use patient monitored devices versus when I do think that patient needs something that I implant in patients' bodies to monitor rhythm problems. So there's a difference. So I will have to discuss with the patients, give them the options, but I do encourage a lot of my patients to use wearable devices for symptoms that are concerning and if we don't have a good diagnosis.
Okay. So where do you think the future lies for these ongoing developments? Do you think the Apple Watches will become more accurate over time, or we'll find more things to record with the Apple Watch?
Absolutely. I think we have to stay tuned. As you know, technology is developing so fast.
Yeah.
They're going to be more sleek, they're going to be more accurate, faster. And the most important thing as a doctor, I would say, there has to be a better method of communication between the patient and the doctor through the devices and appropriate care. That will take some time. Technology will advance very quickly, but I think that's what's going to happen. And in an ideal world, if patient is sitting at home having an abnormal arrhythmia, patient doesn't have to even make a phone call. I get a notification and I immediately alert the emergency team to take care of the patient, there itself without any delay. That would be awesome, you know. So that's where I think there is a lot of work to be done, but it is quickly and at a very fast pace, revolutionizing the technological field, especially the artificial intelligence is going to be huge.
Yeah. You mentioned arrhythmia, and coincidentally, this is the third topic we'll be going on to right now, followed by Dahran, taking the lead from here.
Thank you, Taha, for that. And now we'll be moving on to the ablation of complex life-threatening arrhythmia. So first of all, I wanted to ask you, Dr. Khaji, what a normal heart rhythm was.
What is the normal heart rhythm is? Is that what you asked? Sorry.
If you could describe that, please.
Absolutely. Thank you so much for the question, Zahran. And as far as the heart rhythm, what amazes me about the heart as a unique organ in the body is it's a muscular pump which has an ability to pump blood to all organs that every organ needs as its food. For it to pump efficiently, it needs electrical signals, not just randomly, but in a very synchronized fashion, where the top chambers of the heart and the bottom chambers of the heart are in a perfect sync, so that the top chambers of the heart, when they receive the blood, they are able to fill the bottom chambers, and then the bottom chambers pump. So there is like initial signal starting in the top chamber, going in the bottom chamber, waiting for the top chambers to do their job, then pumping. So this is done purely because the muscle cells of the heart have an amazing capacity to generate their own electricity through alteration in the electrical currents that are generated by positive and negative ions across the cell, such as sodium, potassium, chloride, bicarbonate. Just by changing the positive and negative ions creates electrical signals in such a phenomenal fashion and let the muscle contract or pump based on those signals. So heart rhythm is also called a sinus rhythm, where it starts from the top chamber of the heart, goes to the bottom chamber of the heart with a little bit of delay in the middle so that there is enough time for the chambers to empty and pump the blood. That is what is a regular heart rhythm.
Thank you very much for that answer, Dr. Khaji. I wanted to focus on a word that you mentioned before previously, and that was arrhythmia. Could you please elaborate on what arrhythmia means and its associated symptoms?
Excellent. That is my life, my living, and what I do every day is because of arrhythmia. Because arrhythmia is essentially means an abnormal heart rhythm disorder. Okay, means heart rate, heart how it beats. Is it has a normal rhythm has certain qualities. That means the heart goes and beats certain number of times a minute. For example, normal heart rate is like 60 beats per minute to up to 100, 120, 130 as well. And also how it beats, regular, irregular, it's a regular rhythm. So any deviation from this regularity and the amount of time it beats is called arrhythmia in birth tense. Anything that is slow heart rate, that is less than 60, is called bradyarrhythmias. Means brady means slow, bradyarrhythmias. And anything that is above heart rate of 100 typically is called tachyarrhythmias, which means, so both these combined together, arrhythmia is an umbrella term for anything that is related to abnormal heart rhythm situation. And there are a lot of there is a huge spectrum of arrhythmia problems ranging from mildest to severe sudden death like situation as well, and we can talk more about it down the road.
We can actually talk about that right now. I actually wanted to know a bit more about what the differences are between simple and complex arrhythmia.
Okay, no, that's a great question. And as for simple and complex, I would say, to be honest with you, every arrhythmia is fascinating to me rather than simple versus complex. I think every arrhythmia is complex in a way. There's nothing simple about it. But when you say simple arrhythmia is complex, I think the definition of complex arrhythmia is more for the doctor to appreciate it rather than the patient. I don't want to tell patient that, hey, you have a complex arrhythmia. He may have anxiety about it. But more for a learning student point of view or the doctors, complex arrhythmias are the one where it is difficult to diagnose, where there's challenges in treatment, there is high risk procedures that needs to be done, and the success of these ablations or treatment for these arrhythmias becomes a little daunting task. That's what makes arrhythmia a little complex. Whereas simple arrhythmia is pretty straightforward. You see what it is, you know where the problem is, you go and take care of it, done. So, and I think this is a little bit of a subjective differentiation in terms of simple versus complex. But if that is what I think the terminology is coming from, that's okay. From a patient point of view, any arrhythmia is bad or complex.
Okay, thank you. That was actually quite a lot of new information for me. But I actually wanted
Good.
to know what complex arrhythmias could be considered life-threatening. Is there a distinguishment between that?
Yeah. I would say arrhythmias can be defined between life-threatening arrhythmias and arrhythmias that are more of a annoyance, can cause symptoms where you'll have heart racing, you'll not feel well, you're tired, versus arrhythmia that can kill you instantly. Now, you might have watched, you must be soccer fans, I believe. You watch a lot of soccer games. I use soccer because in America they call it soccer, but it's actually football, because football in America is different term. But you have seen, and I think recently, maybe in the last 2, 3 years, where, athletes passing out in the middle of the field and dying, CPR being done. Now, that is an example of sudden life threatening arrhythmias, which we called, the reason that happens is called ventricular fibrillation. So these are the life-threatening arrhythmias. You can call them as complex arrhythmias by definition because they are very difficult to treat sometimes, but we can prevent sudden death by implanting devices such as defibrillator. So to be honest with you, the most dangerous arrhythmias are the arrhythmias that come from the bottom chamber of the heart called ventricles because they are the main pumping chambers. If those pumping chambers go abnormal, then you're in serious trouble. Okay. So passing out, where you people dropping dead on the street while walking, videos that you might have seen on YouTube, or athletes, passing out while playing the game is a great example of sudden cardiac death. And I think the best example is that of Christian Eriksen. He's probably a Danish soccer player who actually was successfully resuscitated. This was probably in the last 2, 3 years. I don't remember the exact date, but I remember the scene where he was resuscitated. He did get a defibrillator, and that's what an electrophysiologist implants. And I heard he has been playing back after his survival from a sudden cardiac death situation.
Yes, I have heard of that in the news. And moving on to the next question. How do you diagnose complex life-threatening arrhythmias?
Yeah, that's an excellent question. I would say a very, a lot of things can be said, but there are two ways to diagnose a complex arrhythmia. One is simple traditional ECG that we use, and that's what, tells us and gives us, information. But when all the tests, such as we also do an ultrasound of the heart called echocardiogram, that typically does not give much information about the arrhythmia as such, but gives more information about the heart function and abnormalities on the heart function, valves, and such as that. But in order to know and diagnose really sometimes abnormal heart rhythm problem is what is called electrophysiological study of the heart. What it is an invasive way of diagnosing heart rhythm problems where I took patients to the operating room. They are put to sleep by anesthesia, and I passed the catheters, which have basically a simple straw size materials that are advanced into the heart chambers and placed. And these electrodes, which are sitting on these wires, they are in touch with the heart muscle and they record the electrical activity of the heart muscle. And they give me so much information. And what I can do is I can stimulate the heart in certain ways that I like in order to cause that arrhythmia to happen, which is called induction of an arrhythmia. And I do that. This is my every day, every week type of thing where I do, diagnose a heart rhythm problem by doing that induction. And that's probably the best way. We use a lot of cool technologies such as X-rays, such as electrical signals, and also something called as mapping. And we'll talk a little bit more about that as well down.
Yes, we will. And thank you for that. When researching about this topic, I did come across this very interesting term that I didn't quite fully understand, and I hope you could help me with that. But could you please enlighten me as to what arrhythmogenic substrate is?
I think that's a very high level question. I really appreciate your enthusiasm and making some homework about trying to go and try to look for this term. So that's a great question.
Thank you.
As far as arrhythmia substrate is concerned, what it means is this. As I said to you, these arrhythmias originate from the heart muscle. Now, the heart muscle is like a house. It is a big four-chamber structure, right? Now, when arrhythmia arise and somebody has an arrhythmia, right, when we see them, the biggest challenge for us as a cardiologist is which part of the heart this arrhythmia is coming from. That is like trying to solve a jigsaw puzzle, you know what I mean? Like where this problem is coming. And because why that is important is if you know where it's coming from, then you go and do an ablation, which is application of heat energy or cryo energy, liquid nitrogen, and you get rid of it. So in order to find which part of the heart muscle this is coming from, so essentially that part of the heart muscle where the arrhythmia originates is called arrhythmia substrate. Okay. And the best example I would give is, for example, if a patient has a rhythm called ventricular tachycardia, which is a abnormal life-threatening rhythm that comes from the bottom chamber of the heart called ventricles. Now, when I do ventricular tachycardia, I induce it, as I tell you, I stimulate the heart and I see the ventricular tachycardia happening. Once I see that, this is the arrhythmia this patient has. Now, where it's coming from. Now, I identify a little piece of heart muscle tissue in the heart by my mapping or electrical signals where I see scar in the heart. And that area, it could be a 1 or 2 centimeter patch of scar, which is abnormal. And that would be called as arrhythmia substrate. Typically, that's what it means. It's a part of the heart muscle which is responsible for generating this abnormal heart rhythm disorder.
Thank you very much. That was actually quite helpful and much more intuitive in an explanation compared to the websites I was looking at.
Absolutely.
And moving on, I would like to know more about the treatments for arrhythmia. I know that you did mention ablation. Could you elaborate on that?
One of the reasons I chose this career was essentially because of ablations, because I think that is the most coolest thing that you can do to take care of a patient and fix a problem without doing much of an invasive open heart type of surgery. What is ablation? I'll tell you this. It is essentially taking a catheter, which is the size of a straw. Now, as you have, we have discussed about what is arrhythmia. We have discussed about where the arrhythmia is coming from. We talked about arrhythmia substrate. And let's see, we diagnose the problem and we know where is the arrhythmia substrate, and we have to go to a particular location in the heart and cause a kind of, in a rough terms, damage to the heart muscle so that it stops causing that arrhythmia problem. An ablation is essentially going to that particular part of the heart muscle, identifying, confirming, and literally applying heat energy, so it's like literally like heating or cooking. Sometimes I even joke around when I'm operating on the patient, which is barbecuing, because you're literally cooking the meat kind of situations, but in a very specific small areas of the heart where application of that energy will essentially cause enough damage to the muscle so that arrhythmia does not arise, at the same time preserve the heart muscle function as it is before without affecting the heart function, which is fascinating. And that way you can fix patients' life-threatening problems. And what I really like about this example of ablation and why this is so cool and why I really liked is, imagine this same arrhythmia treatment used to be open heart surgery. And just to give an example how this has revolutionized in the last 40, 50 years is 40 years ago, that means today is 2023, right? If somebody had to get a treatment for arrhythmia in 1980, probably most of you who are listening were not born, is by a method called open heart surgery. You cut open the patient's chest, take their heart out, identify where the substrate is, look at the eyes, apply some heat, burn it, and then hope for the best. Patient will be staying in the hospital for at least 10 days. And that's how they used to be treated. Okay. Now in 2023, literally, patients comes in the morning. I have a little catheter that passes through the groin, like an IV that you get in the hospital. Catheter goes up. Patient is almost half awake, not even sleep. There's no skin cut to the body at all, zero. Procedure lasts 2 hours. Once the ablation is done, it depends on the type of ablation as well. Patient, after the procedure done, let's say procedure starts at 8 o'clock, we are done by 10:30 in the morning. Patient will be washed for another few hours. 3, 4 o'clock in the afternoon, patient is going home without an incision. And that is a procedure that has cured his life. So we have revolutionized in terms of treatment of arrhythmias with ablations. And that's what major part of my job on a day-to-day basis is, and which I really love.
Thank you very much. It is very interesting, and this does seem like the thing that does stand out most in cardiology. I do know, as you have briefly mentioned, that there are types of ablations. Could you please elaborate on that?
So there are actually, to be honest with you, there are only two ways. Ablation is essentially, kind of damaging the heart muscle tissue in a way that it does not cause arrhythmias. And the two most, probably three, the third one that has emerged in the last 2 years is a pretty cool way of doing it. The typically used ablation method is called radio frequency energy, so heat energy. Okay, and that's what I use when I do ablations. The second method is using too much cold, like a liquid nitrogen. Okay, so temperature up to minus 79 degrees Celsius being used to freeze the tissue, and that way you can damage. It's called cryoablation. I don't do them as much. The efficacy of cryoablation is similar to regular ablations, radiofrequency ablations, but I would say not as amazing as radiofrequency has been. The third one that has come up is called PFA, and the technology it stands essentially for, it's a way to cause holes in the cells, like punching holes in the muscle cells at a very specific spots without causing any heat or cold damage. That way, cell that is causing a arrhythmia will die instantly within a fraction of a second. Okay, it's called PFO. It's evolving right now. Trials have been going on. It works amazing. There are some caveats, but that could be the future in the next few years.
Thank you very much. That was actually very interesting. I haven't heard of PFA before, despite my research, and this is the exact reason why we have you on this podcast, so that you could tell us about these things that we might not know. And moving on, I do want to know more about what intracardiac echocardiography is and when is it used.
That's a great. I really am impressed by the quality of questions in the whole podcast, and one of the reasons I also say it's a great quality is because I know the answers to those questions. If I didn't know, then I'm going to be saying, "Oh, that's a bad question. I don't know." So, but no, that's really good question. Intracardiac echocardiography. I use it every time I do ablation patients, which are high risk complex ablations. What it is, as I told you, we use ultrasound, that is echocardiography, right? To look at the heart muscle, how it is beating, chamber size and everything. It's a black and white picture of the heart muscle, right? So intracardiac echocardiography is essentially sitting inside the heart and looking at the heart kind of vision. Okay, so it gives me an image of the heart muscle, chambers and everything, because when I'm doing ablations, it is one of the most delicate, at the same time extremely dangerous part of the body, where something goes wrong, patient can die on the table. All right, so what I am doing is, when I'm doing ablation, working on a beating heart. So heart is heart. We cannot stop the heart to beat, because if you do, then patient is dead, right? Technically,
yes,
literally. But you cannot do that. You have to work on a beating heart. But at the same time, when you're passing these wires, catheters, I use needles sometimes. poke holes in the heart. Sounds, kind of gross and horrible, but these are very minutely, delicately done, where I need some sort of imaging to make sure that I'm not causing any problem. I can see any problem that is happening, where things can go wrong. So intracardiac echography is literally my eyes, where I can see exactly in the heart chamber where and what is happening. And that's how it helps me.
Thank you. And I want to know what the advances have been in the mapping systems used for carrying out ablation.
Absolutely. This is my favorite question, I would say, because, I cannot tell you how much my life would be impossible to do every day if we don't have mapping. And what is mapping? I'll tell you briefly this. Now, imagine you have to robotically or remotely go and hang a painting in a wall of the house, okay? But you cannot go into the room, that particular room, but you have to sit somewhere else, all right? But you have to do it using a robot, right? So you cannot feel where you are. You cannot see how big is you have no idea. All you know is it's a room, but what are the dimensions of the room? What is, where the wall is and how to hang it, how much pressure. If you put too much, if you put it at the wrong place, the wall could fall off. If you just keep on hitting in a wrong place, a nail where there is no substance, you could cause damage, right? So when I'm doing ablation, what I really need is some sort of an imaging system that can help me to know exactly where my catheter is inside the heart. Because intracardiac echocardiography, which I told you, it helps. It is not the best. Okay, I want to know exactly millimeter by millimeter where my catheter is moving, how it is moving, how much pressure I'm applying. Am I applying too much pressure, too less pressure? And when I'm applying ablation heat energy, is it delivering effective lesion? All these things are helped and given to me by mapping. The question is, what is mapping? Mapping is essentially when I move my catheter, it creates an anatomic a animation image of the chamber of the heart, so that it creates a 3D cartoon picture of how the heart chamber looks like by moving the catheter. More I move the catheter, it gives me the image. So I exactly know for every patient how it is different heart chamber in the size, shape, because we always have variations. I exactly know where the structures are. And then I mark, and when applying the energy where I'm burning literally in the heart, I exactly know how much pressure I'm applying so it gives me all that information. And if you Google, called carto mapping, it's one of the most commonly used, and that's what I use in my operations when I do ablations. Is called carto mapping systems. And you'll see a lot of colorful pictures of the chambers of the heart, and that's where this literally helps. So because majority of my work is very much dependent on mapping system. If I don't have a mapping system, ablation is extremely long and dangerous. So that's why mapping is very, very important. It's a long answer, but that's
No, it's very appreciated. It just goes to show how specific and precise you have to be in these procedures. Even using something other than your hands, you do
correct.
still have to be quite precise.
Exactly.
And
Oh,
there is also,
you know what?
yes,
Sorry to interrupt. Can I give one funny analogy to this situation?
yes, of course, go ahead.
There was a mechanic who was there, who was very popular. A guy comes to him for getting his car repaired because the engine wouldn't start, and the mechanic says, sure, I will have a look at it. And the guy says, I've been trying everything, nothing seems to be working. But when I open the hood, which is the trunk of the whatever you call the front part of the car, right?
Yeah.
I don't know what's wrong and where to figure it out. All right. So what he does is the mechanic opens it and looks at it. After looking for half an hour, he takes his hammer, he hits with the hammer right at one place. And then he tells the customer, go and start your car. The car starts automatically. The customer is super happy. He says, you are amazing. You did so good that I could not tell what to fix, and you exactly knew what you're doing. And he says, what are your charges? And the guy says $1,000. I'm just giving you this example, making it up. All right. The guy goes shocked. All you did was you had to hit me the hammer, and you're charging me $1,000 for this. And he says, well, hitting me the hammer is just $1. I charge $1. But to figure it out where I have to hit rightly is $999. Okay. The moral of the story is mapping system literally helps me to identify the right place where I need to do the ablation. Okay. So it's important. You can go and do ablation. So that's the analogy of giving you, I hope you get it. Like, mapping gives me exact precise location where I should be doing the ablation.
Yeah, I think that shows qualitatively how important it is compared to simply doing ablation. The location, the ability to find that specific area with this advancement in technology, that's the main development that's massively helped you and other cardiologists.
Exactly. You got it right.
And how do you ensure an ablation is complete?
Excellent question once again. I like it. And I think the answer to that question is this, that, the whole idea of ablation is to cure an arrhythmia. What I first do is, before I start the ablation, is try to bring the arrhythmia and see if it comes up. And when it comes up, and I know that that's where the arrhythmia is coming from, I do the ablation. And my goal of ablation is essentially to make sure that I stimulate the heart in many ways so that arrhythmia does not come back, and that's a way to observe. So I think the best way to say success is patient says, oh, I never had arrhythmia, which you will know down the road. But if I stimulate the heart and no arrhythmia is come back, that's a good sign. I will also have some information through electrical signals, which tells me exactly, if arrhythmia is successful. Okay.
Yes, and I have heard of the use of chemicals for actually being able to ensure ablation is complete. Have you ever, and do you know anything about that?
Sorry, I missed the last part of the question. What you said, the success of ablation?
No, the use of chemicals for ablation. Do you have any knowledge about that such a procedure?
People have used, I'll tell you, sometimes ablation, the common ways to ablate is typically, using of radio frequency and cryo. Okay.
Yes,
But
sorry, I meant
some
to ensure ablation.
ablation. But people sometimes have used alcohol. Okay.
Yes, yeah.
Where alcohol can be injected into the vessels, and you can do an ablation using alcohol, and that is an option. It's used very rarely in extremely specific cases, especially with the areas, because when you do ablation, you cannot access every part of the heart. There are some areas of the heart that you cannot access. When you can't do that, then you use a little bit of alcohol, because alcohol, as you know, is the world's best known toxin, to be honest. So it kind of has ability to kill the muscle. So you can use alcohol to kill the muscle tissue, and that has been used in very, very specific cases.
Thank you. And are there any difficulties or problems that may occur before, during, or after the procedure?
Absolutely. That's my everyday, day-to-day job, where I tell my patients about all the complications, which range from bleeding, infection, perforation of the heart block requiring a pacemaker, stroke, heart attack, even death. Those are the complications that can all happen after or during ablation. Fortunately, in my, a decade of experience, I've never had to deal with anything such as life-threatening where patient had to die on the table. We do see some common complications such as a little bit of bleeding, infection, but that's about the most common. Otherwise these procedures are overall very low risk and the success rate is very high. So there's always risk.
Yes, and how often do you carry out this procedure in a year?
How often? I would say average, probably per week, I do at least 2 to 3 ablations a week. So convert that into 52, so probably around 200 to 252 ablations a year.
And that is a lot of ablations.
Absolutely.
And in your experience, how successful has the operation been? You have said that it has very low risk, but if you could give a
I would say,
number, for example.
if depends on sometimes arrhythmias, the majority of them are above 90% success. 90%. Some arrhythmias are almost, we never say 100%, 99.9%, but majority of them are pretty good, extremely successful procedures.
And that's good to hear. And for the future, what do you think about any advancements or new developments in your expert opinion? Is there anything going on other than you have mentioned the PFA, maybe in mapping
Yep.
systems or ablations themselves?
Yes.
Is there any more advancements?
There is going to be more advancement because you know what? Always we are making sure that it is better for the patients. That's the goal. Lesser the incision, quicker the procedure, quicker the recovery time, or safety of the procedure, ease of time. If I give you an example, 20 years ago, an ablation would last for 10 hours. Okay. Patient would go in the room at 9 o'clock or 8 o'clock in the morning. By the time patient comes out of the OR operating, it would be like 6 p.m. Okay. It'll be crazy long hours. Now ablations can be like you start at 8, you're done by 10:30, 10, 11. Okay. So there has been huge advancement at multiple levels. There is integration of artificial intelligence, there is technological advancement, more tools, more effective delivery of lesions, early diagnosis with all the gadgets that we have, and quicker recovery times for the patients. And I do think that we are always looking to every day improve and a and there is a lot of things that are happening.
Thank you very much for answering these questions, Dr. Khaji. I'd like to now
Absolutely.
pass you on to Fahad, who will be asking you about the world's smallest pacemaker.
Thank you, Zehran and Daha, for those questions. It's been a pleasure, Dr. Khaji, for you to answer all these questions and engage us with this information. So I would like to carry on with section 3, as you had mentioned before. This is about the pacemaker, and in particular, the world's smallest pacemaker. So first of all, could you tell us a bit about this new pacemaker implant by Medtronic? Its name is Micra. Could you just tell us about how it works and how it's implanted as well?
Excellent. Thank you so much for the question, Fahad. And this is another exciting part of my field, which is pacemakers. And as you know, pacemakers are implanted in patients who have slow heart rate or bradyarrhythmias because pacemakers deliver energy and improve the heartbeats. So talking about all this time was ablations, which is for heart rhythm disorders that are fast, So now we're switching our gears to the slow heart rate problems, and pacemaker is the way to treat a dangerous slow heart rate problems. Micra has revolutionized in terms of how the pacemakers look like and the leadless technology. And this came back probably almost a decade ago now. So it's not very new. It's been there for 10 years. And I had the pleasure of implanting some of the first new Micra pacemakers in the country, along with the team when the trials were going on in the United States. In fact, I implanted also a first of a kind Micra AV, which is an upgrade from a basic type of Micra in my hospital in the region. So I'll tell you what it is. It is a pacemaker, and as you know, pacemaker is to improve the heart rate for patients with slow heart rate. Traditionally, pacemakers have a battery that is a size of typically these days, I don't know how to describe analogy, a size of 2, 3 coins, Is it a pound, if I had to say in UK terms? Or here in America, we say quarters, So it's like a size of 3 to 4 centimeters in diameter, like a metallic device with wires attached to it, and those wires go inside the heart. Micra, in contrast, is a device that is literally size of your little paper clip. There's no wires. Everything is there in that little piece of tissue, piece of metal. And if you want to Google Micra pacemaker, you'll see the image and you can appreciate how small it is. It is the smallest pacemaker. It works exactly like a regular pacemaker. And the way we implant these pacemakers is I go through the groin of the patient with the delivery system and then enter the heart in the bottom chamber of the heart on the right circle, right ventricle. And this leadless pacemaker has little anchors like the boat anchors you see if you have done the boating or ships. And these anchors literally stick to the heart muscle, and that's how it gets stuck to the heart muscle. It has ability to detect signals and smartly deliver electrical signals to the heart whenever it needs. So it's not like just acting nonstop without thinking. This little piece of device has a brain. It detects when the heart rate is too fast, it backs off and does not deliver the heart. And when it is too slow, it recognizes that and delivers the energy. The batteries for Micra AV last for 15 years, which is an amazing thing. And patients love it in the sense because there is no incision in the chest, which is typically for pacemakers. Batteries last longer. They have no restrictions. Recovery is excellent. And there's nothing that can be seen on the body externally that will be, appreciated. So it has definitely revolutionized pacemaker world.
Thank you very much. That was a lot of information there. And yeah, so just carrying on, you did mention this before about it being a leadless pacemaker, and obviously in this day and age, normal pacemakers are usually with some leads and cables. So in your opinion, how would this how would this be different from not only just normal pacemakers, but other leadless pacemakers? What would you say the main differences are and how this would benefit other patients?
Traditional pacemakers, right? I think, not everybody who needs a pacemaker can get a Micra or leadless pacemaker. There are some exceptions because typically when we implant pacemakers, somebody needs 2 wires, somebody needs 3 wires, and somebody needs just 1 wire. If your patient needs only 1 wire, then leadless pacemaker is a good option to have compared to traditional pacemaker. So I would say, the biggest differences are first, you need to understand who needs what type of pacemaker. So if somebody needs 2 wires, leadless pacemaker is going to be not helpful. Although, having said that, now the leadless pacemakers are developing technology where they're trying to mimic, even though they are in one chamber, they can try to act and, which is phenomenal. And that's what I implanted 2 years ago, as an upgrade to the basic version of the leadless pacemaker. So everybody, and sometimes pacemaker, I also implant defibrillators, which is treating the heart rhythm as is fast and shock the patient. How you might have seen in James Bond movies or any of the movies where patients who is dying, they shock them out of the chest, right? So I implant those defibrillators. They look like a little bigger than pacemakers, and they can ability to shock the patient and save the life. And leadless pacemaker do not have that capacity. So, they're just pacemakers. They cannot shock the patient. So those are some differences in terms of, size, durability, type of patients, things such as that.
Okay, thank you very much. Now, you were mentioning about how this pacemaker is obviously different from others. And by our information, we've also worked out that this pacemaker has a wireless connection. And so obviously, wireless connections these days, they carry advantages and disadvantages. So just looking at the disadvantages side, would you say that this wireless connection for a pacemaker increases the risk, such as malware attacks, or troubleshooting issues and things like that?
You know what? The good news is this. So far, to my best of my knowledge, the malware attacks, virus attacks, somebody else controlling the pacemaker remotely has only happened in movies, especially Hollywood movies. Okay. So I think theoretically somebody can mess around and do it. But these devices are so well secure that no one has ability to mess around with them. Okay, because we are talking about life and death situation, right? So to my knowledge, it's almost impossible to mess around with these devices by attacking malware attacks. Imagine if that was the situation, then I don't think anybody would want to order a pacemaker, because then it would be like Windows or Apple products. You have to upgrade every year. Some things like that. It's going to be ridiculous. So the answer is these are very much proof from any sorts of external influence or malfunction, but theoretically, it is possible.
That sounds very promising. You saying that obviously these are very rare or almost quite impossible. Obviously, then that shows that, as an advancing future, obviously we probably have less to worry about. So my next questions I would like to carry on with are obviously the practical side. And in terms of practical, I mean actual implants. So what would you say the problems or risks are that are associated with the operation and pacemaker itself?
Yeah, great question. And everything I do in procedure-wise, there are risks involved. Okay, and pacemaker procedures are risky as well, such as bleeding is common at the site of operation, incision, bleeding, infection. Sometimes you can cause a serious uh, perforation of the heart, causing bleeding around the heart. You can also cause stroke. There can be heart attacks, and sometimes patient can die as well. But the good news is the serious risks of complications is less than 0.5%. And in my own experience, I would say they are even less than 0.1%. So, complications do happen. That's a part of our day-to-day life as doctors taking care of these patients. We do expect always something, but we hope for the best and things go well. So it is very important to keep eye on those things. And complications, patients who get pacemakers with wires, the wires can dislodge and that can lead to malfunction of the pacemakers too. So those are the complications.
Okay, thank you very much. Yeah, it does sound obviously, as all operations and procedures go, they do carry risks, and so yeah, I mean, the least risks, the better, obviously, as a emerging future. My next question would be, obviously, as you said, you have treated patients using the micro pacemaker. So how successful would you say that the micro in itself as a pacemaker and the treatment has been successful in your experience?
Absolutely. I think every patient who gets a pacemaker, I would say a success, and success is almost 100%. We very rarely say in medicine we have 100% success, but I'm so proud of my field and the pacemaker world is, when you put a pacemaker, it's success 100% of the time. And the best example of a micro pacemaker patient that I'm going to tell you is this. I had a patient who is 95 years old who came, he's a chemical engineer, retired, a really smart guy, 95, okay? Came with a heart block. I put a micro pacemaker on him, and I saw him just recently. It's been 5 years almost. He's doing really well. He still walks around in his home, does some course, He's active. I don't think he drives, but he's fairly independent. And he's going to be celebrating his 100th birthday in October, in a couple months. So I think that makes me happy and so satisfied professionally that when you make a difference to patients' lives by implanting a pacemaker and they live their life, they live their life. So I think pacemaker is 100% success.
Yeah, thank you very much. Yeah, that's very promising. Obviously, for any patient that comes with such a serious problem, immediate attention is required, and obviously, the higher the success, the better. And my last question for this section in particular is, obviously, you have used the pacemaker and have probably operated with it as well. So, in particular, the micro pacemaker, how has it affected the operation of inserting a normal pacemaker? Obviously, because the pacemaker in itself is so small, has it caused any complications, or has it been easier for you? And following on from that, how has it shortened the duration of the procedure and recovery time? So has it made it easier, or has it reduced the risk, and etc.? So could you answer that, please?
Excellent question once again. And I think the answer is the micro pacemaker is certainly, typically either same time or even much less time. I would say the shortest time I have implanted a leadless micro pacemaker in a patient from inserting the tools to, walking out of the patient room after the procedure is like 11 minutes, which is insanely fast, okay, compared to a traditional pacemaker can take up to sometimes 1 to 1.5 hours. So time duration is less with Micra. Patient love it because there is no incision. When you put a traditional pacemaker, there are a lot of arm restrictions that they cannot do for 1 month. So with Micra, you don't have any arm restrictions, so those are the huge advantages. The complication rates are pretty much similar. So you have not only got similar complication rate, but a huge advantage of time, convenience, incisions, and the ease with the patient, and all these makes it an excellent option, Micra, for patients who are suitable. Obviously, not everyone should get Micra, but only selected patients should get Micra.
Thank you. That's very helpful indeed. All the information that you provide us will be very useful for us in the future and anyone else that's listening to the podcast. So that concludes the last section. However, we do have some additional questions, and they just encompass just general knowledge about cardiology and the future going forwards. So my first question to you is about artificial intelligence. Obviously, the growing world and the adaptations of AI into different scenarios and different works and stuff. So how would you say that artificial intelligence is currently being used in cardiology? And can you give us some examples?
Yeah, this is probably the big word in the world today is, as they say, I don't know, what I hear in the news these days is there are 2 or 3 words that are going around all over the world that's going to be future. Is one, artificial intelligence, diseases, and 3, cryptocurrency. Just a little off the topic. So
Sorry, could you
clearly
repeat that,
artificial intelligence
please?
has, been, I said the 3 things that are right now being talked about all over the world that have generated huge potential for future help for genetic engineering to treat diseases, like, basically them. And third is cryptocurrency, not related to healthcare, but especially when I talk about mapping for arrhythmias, when I talk about remote monitoring, or management of pacemakers and defibrillators when I'm investigating them through iPads. These are clearly examples of machine learning telling me all the information. Because you know what? Artificial intelligence, the best thing it can do is you have to remember that it's going to make human life much more easy. But at the same time, it is very important to recognize that it's never going to replace the human brain. Okay. And it's artificial. It's nothing, the name itself suggests. And the beauty of artificial intelligence is the fact that it has superhuman quality to absorb the data, process the data, and then selectively give you the information that you need to make your life easy, right? So, when I read an ECG, AI will already make a diagnosis out of that based on information. So that is really helpful for me because, it's not 100% accurate. Obviously, I have to check and make sure everything is okay, but it does make a difference. AI has been phenomenally progressing in our field, and we use it on a day-to-day basis. But what we want ideally, where the future of AI is, where AI will help us detect problems quickly, treat them, identify people who are at high risk. For example, the best example, if I want you to understand, and maybe this might be answer to some of the questions that you want to maybe ask me, I think, is if some student who is a very good football player, right, and he wants to play for, I don't know what your favorite, you know, um, football club is. Let's say Liverpool. Okay, I don't want to offend anyone who is not a Liverpool fan, but I like Liverpool Football Club. And if this is this kid who wants to participate and develop a career as a striker in the Liverpool Football Club, but there is a risk that he wants to assess, which is what he has a family history of heart disease and he has got some tests done, all look normal. Can we predict his risk of dangerous heart rhythm problems? Because that will decide his career. Like what happened to Christian Eriksen, right? Sudden death on the field while playing. Can we predict sudden cardiac death in some patients? And if we can predict, we can prevent problem. So AI role would be to gather all the genetic information about other clinical data, process, and can we model it in a way that it can predict who out of 100 people that we're going to screen the athlete more likely going to develop cardiac arrhythmia. So that's where the role of AI is going to be huge.
Thank you. Yeah, that was very helpful as well. And giving us extra information always helps. And yeah, as you said, AI seems to be obviously going towards two different paths. It could either be in the right path or the wrong path. It just depends on the people who's using AI and obviously their intention with it. My next question would be more in the essence of cardiology because it's your field. And I would like to ask you, how do you think artificial intelligence will be involved in the field of cardiology in the future? So obviously you've talked about ablations, you've talked about pacemakers, you've talked about relevant stuff. So maybe in the topic of ablations, how could you say that AI could help you with ablations?
I do think that it's going to be a huge role because what we have a problem in ablation still today is in certain patients and certain cases, we do not know which are sometimes the best places to get rid of arrhythmia when you do ablation. So identifying the substrate, and trying to figure it out to know where is the exact location. Because as you told you, some cases we know exactly where to ablate, but sometimes it's challenging. And AI could definitely help us to identify area that needs to be targeted and targeted efficiently, because not only just targeting, but at the same time when we target, did we deliver effective treatment or ablation energy so that the problem is not going to happen again? All these things AI could certainly help us.
Yeah, thank you very much. Yeah, that's very helpful again. And the final question for this entire podcast, and hopefully, it's been a great lesson for anyone who's listening or watching. The final question would be about the future and about obviously things that may not have appeared right now, but more so about predictions. And the question is, what other developments do you predict may play a significant role in the future of cardiology? So obviously we already have technology moving forward, AI, but is there anything that maybe you haven't seen yet that you would want to see or could possibly help you even further than things that are helping you right now?
Yeah, absolutely. I think, you know what, we are in really exciting and fascinating times in the um, world right now with regards to a lot of things going to come in technology and medicine. And what are those? Here's the thing, we are talking already about ablations without touching the patient. Wouldn't that be so cool? Like, even for ablations to be done, I still have to do pass wires in the body and everything. But there is something that is going on right now where we are going to ablate a patient without touching, sitting 20 feet away from the patient, exactly identifying where it is. So using that technology, and that's already in progress. And some places we already started doing that in America, okay, and somewhere in Europe as well. So, the goal is to keep minimally invasive, less cutting, causing trauma. Then, role of AI in helping and managing quickly, predicting the risk, treatment efficiently, quicker procedures, quicker recovery, you know, identifying high risk patients. These things are going to happen as well. As far as the devices are concerned, these devices have limited time span, such as 10, 15 years max. You know, as you know, today you have cars that can be charged, like Tesla or other electrical vehicles. The idea is, if the cars can be charged, why not pacemaker batteries or defibrillator batteries? Why do we need to replace them? So, from a ethical point of view, from a you know treatment point of view, because now we are dealing with a human body, it's not a product we are dealing with like an iPhone or a Tesla. So those changes are going to come. There are going to be more charging options available, long lasting batteries, the pacemakers are going to be even smaller. I think there is a lot of potential to grow in the field of cardiology, and I see a great future. And who knows, I think when one of you guys who are listening today to the podcast, and when you become and choose this field, by that time there'll be a huge revolution in the field of electrophysiology, where things have changed quite a bit. So it is going to be really exciting.
Yep, thank you very much. It has been a pleasure to talk to you, Dr. Khaji. And as always, obviously, we always look forward to hearing any new information. Obviously, research can only play a part, but obviously, with talking, even in a podcast to specialized doctors massively helps us and other people who are listening to the podcast in achieving a medical dream. So thank you very much.
Absolutely. And thank you once again so much, Taha Kazi, Zahran Punekar, as well as Fahad. You did an excellent job asking really great questions. I enjoyed the session, and I wish good luck to all your listeners, and keep in touch and ask me any questions if you have offline too.
Yeah, thank you for your time once again. Zahran, do you have anything to add to this?
No, not really. Just thank you very much for your time and helping us gain a greater understanding into your field. And it has been very enlightening for us. Is there anything else you'd like to add to end off?
All I can say is I hope one of you become an electrophysiologist. That'll be awesome for me.
It is a very interesting field, yes.
Yeah. Right. Yeah.
But yes, thank
That's
you.
awesome.
We're very honored for you to come onto our podcast. And
Absolutely.
hopefully, maybe in the future we could record another episode when you're free.
Yeah, no problems. Give me a heads up. I'll let you know.
Yeah, thank you.